We are looking forward to sharing with you our experience of working with optimizing nurse extenders, particularly the clinical extern role, and to talk a little bit about the structure, process, and outcomes that we have experienced while facilitating the optimal use of this workforce in our setting, which is acute care and pediatrics. So Connie and I are really happy to meet with you today. The objectives, go ahead, Connie.
I want to make sure you can see the slide screen. Right?
I can.
Just making sure you weren't seeing your own features.
Thank you. The objectives today are to talk about the regulatory and policy frameworks that have helped us ensure that we have a really supportive practice for nurse extender roles. We want to also share with you, like I said before, the structures and processes that enable clinical externs as nurse extenders within our context. And we want to talk about the implications for you in your settings and have a lot of time to connect as a community of practice and understand the questions that you have and what are the things that you're bringing to have answered at this webinar. Next slide, Connie. So a little bit about Sick Kids, and perhaps this is a moot point, but we are a pediatric tertiary care hospital. We have an intensive care unit, a neonatal intensive care unit, emergency department, as well as perioperative services. In specifically where we have our externs working right now is within our 14 subspecialty inpatient units, in addition to 2 of our day hospitals. We also have patient care happening across 40 subspecialty outpatient clinics. And here at Sick Kids, which I do think is important in the context of nurse extenders, is we have an all RN staffing model. Next slide, please. So just a snapshot of nursing at Sick Kids is that in my role as Associate Chief of Nursing Practice, we really try to function to make sure that we're creating a supportive environment and culture for practice to thrive. And we're working within this diamond model that we talk about. So here at Sick Kids, we have a very large nursing workforce. We have over 1,800 registered nurses that work within the organization, and they may work within a variety of roles that may extend actually well beyond that slide that sort of talked a little bit about, Sick Kids by the numbers. Our nurses work into many of our leadership roles, including our executive, and they may work in areas of education, research, and clinical care. So very diverse registered nursing presence at Sick Kids. In addition to that, we also hold a very significant advanced practice nursing population. And so within my role as Associate Chief of Nursing Practice, I also have the privilege of being the professional director for all of our advanced practice nurses at the hospital. That's kind of how we think about nursing in the context of credentialing. So we have our credentialed registered nurses, we have our extended class registered nurses, and then what we consider the supportive additional structure of that is the nurse extender role. And that is at this point, actually 49, but we kind of hover around the 50 mark, centralized clinical externs. And those externs are centralized within the portfolio of professional practice. So we have a centralized clinical extern model, and Connie and I will share with you the nuance and details of that program and why centralization was a really big part of what we have done in 2022 to optimize the role of the clinical extern at the hospital. I might just pause briefly and see if anybody has any questions about that overview of structure. And if you do, please go ahead and pop them in the chat. We'll keep an eye open for them, and we can go ahead and advance to the next slide. So I'm going to hand this structure over to Connie, and we're going to get a little bit more of the layers of detail. We're going to peel the onion apart and share with you more of our reporting and distribution.
Yeah, so as Erin mentioned, this year was really a transformative year for our extern program. We have had an extern program at Sick Kids for quite some time, but what we had done is really thought about ways that we could better kind of extend nursing practice, as Erin said, and also increase our extern workforce and support them through. So my role is also new for us in professional practice. We didn't previously have a senior manager level role for us. And so as part of that, we centralized the program this year, starting off with 2 cohorts in May and July, respectively. That meant that we onboarded externs to these various areas that you can see here under kind of a new reporting vertical for us. And we're still learning about it as we go through this kind of initial fiscal year. So reporting through to us now in the Collaborative for Professional Practice are 49 externs, as Erin mentioned. We are currently hiring more right now, and we'll hire more interprofessional externs in the new year, so this number will grow. And you can see that they work across many of our inpatient programs. And as Erin said, our day hospital setting in particular, that is our hematology oncology day hospital, where we do have externs that work there. What is new for us at Sick Kids this year is having externs in our emergency and ICU environments. And in fact, it's been really valuable, both from an extern experience perspective and from a local team perspective, as they've gotten to know the expanded skills that the externs have and actually realize the impacts. So in fact, the recruitment I'm doing right now is focused in on having more folks increase that number for ED and ICU, because we've seen the support be so valuable there. So you can see they work across many areas. The other unique area is our inpatient mental health program, where it's also been incredibly invaluable to add externs into that environment. And so they report up to me centrally from a management perspective. I support their onboarding. I support all of the activities related to performance review and mentorship and coaching and support. We also do have a small FTE dedicated to extern coordination and mentorship, and that's new for us. But right now, what that's looking like is supporting the onboarding education coordination, in addition to our local educators that support those processes as well. And I'll go into a little bit more detail about their education and onboarding as we talk through. What it's really successful with too is helping us partner with the local leadership teams. And there are some matrix accountabilities that we're learning as we go with the new centralization, but I'd say to Erin's earlier note, has been really helpful for us. So to give more context, all of our local programs have a local manager, an educator, and a quality leader support. Some of our portfolios have additional roles like clinical orientation support nurses or charge nurses that have maybe additional FTEs to support unit activities. So within this kind of triad or kind of quad of local leadership teams, they also have a role to support local activities for the externs, that local mentorship and coaching, and support their integration into the unit in partnership with me and with Tiffany, who's the extern coordinator that we work with. And really what this brings us to is how we're hoping to advance these two kind of concurrent aims that we have. So what we really moved out of was the mindset of a clinical extern as a new learner at Sick Kids and a student. We know that they are, and we know that that's a valuable thing for us to pay attention to, leverage, and grow and develop. But to really move us over to supporting them as unregulated care providers that support patient needs and build our robust workforce of nurse extension roles at Sick Kids. So really partnering with nursing to extend care. We also know that it's an important way that we build the nursing pediatric pipeline in particular. And what's really become apparent to us in the pandemic context is that a lot of nursing students have had limited clinical placements. Some of them are still virtual, I'm learning, for this term even. And even more to add to that, their limitations to having pediatric exposures has been a challenge as well. So this has been a really great way to bring folks into the pediatric setting and build their comfort, build that expertise, and get them into the clinical setting maybe a bit earlier. I should note too that we do hire folks that are maybe second going into third year. So we don't just hire externs that are in their final year, for example, and that's been a really great way to get them into the clinical setting even sooner in their education, and a way that we can keep them ideally for over a year actually as externs to integrate into the care setting. And this goes back to really some purposeful ways that we looked at strategic hiring. So when we say we wanted to have a diverse kind of hiring strategy, that meant a few things for us. So it meant really looking to make sure we had a broader representation from an EDI perspective, of course. It also meant that we had to think critically about the schools and the areas that we were recruiting folks from, and be really thoughtful about diversifying that and really doing our best to think of how we would accommodate students that were coming from Queens, for example, or a little bit further than what we typically are used to. And we know, right, our academic health science centers tend to pull largely from Toronto Metropolitan University and U of T, but we wanted to be really purposeful and conscious of diversifying where folks were coming from university-wise, background-wise, and also, like I said, student years of experience-wise as well. To really help with that has meant that we've had to be flexible with FTE and accommodations. So for example, I have 2 folks that go to Queens, and I've had to really navigate through with them what support looks like now that they're back in their school year and they're on site in Kingston, so that they can feel comfortable and balanced kind of driving into Toronto for their shifts. And we get creative to make sure that we can support them. We've also really supported a full-time FTE for the summer months, so when they're outside of the academic year, and then we drop them to part-time, so 0.3 very specifically, when they start their academic year as well. But we do offer flexibility for them to pick up extra shifts and to have varied shift types as well. We'll talk quite a bit more about the standardized care activities, but this has been a really important way that we've enhanced the program this past year. And I'll talk in detail about how we dove into that together. And what we've really started to launch now on the second aim there to develop our pipeline workforce is acknowledging that we are spending a lot of time really educating, setting the externs up for success within our program. And that will only benefit us down the road to impact them as new hire nurses in particular. And what we've been able to do this go round is also centralize and streamline our early offer to RN process. So we have some folks that are graduating this calendar year, actually in December. And we're finding too, with some of the pandemic impacts, some of their end dates or graduation dates are also a bit in flux. So I would say, as you're thinking through your own programs, that's definitely something to pay attention to. Some of them are making up clinical hours, for example, so may graduate a bit later. Some of them are actually graduating a bit sooner. And so what we've kind of landed on is that November is a really great time of year to actually get these early offers out. Sick Kids also has a very centralized and streamlined pediatric nursing orientation program with defined intake dates. And so what we do is we work backwards from those dates to make sure that we're offering at the right time that would enable, for example, an extern that graduates in December to be able to start for our April intake if they choose and feel that they'll be ready with either a temp license or have written the NCLEX and be in general class by then. That said, what we know is most of our folks will start with our next year's September intake, but we are conscious of that. And we want to make sure too that we're showing the interest in them as candidates, respecting and honoring the time they've spent with us and the expertise they have developed, and really acknowledging that through giving them early offers. And so we're working through that right now. So I'll be happy to chat through how that goes with folks later on as we learn. And so I talked about what's kind of set the foundation for success for us, and what we've leveraged are kind of 2 main frameworks. So that is the CNO's guidance on working with unregulated care providers. That's really been the key foundation to all of the work that we've done to centralize the program, and I'd say refine or fine-tune some of the things that we had been doing in the past. We also, as Erin said, we are an all RN staffing model. So we don't have familiarity with working with RPNs like some of your organizations might have, for example. But we did leverage knowledge of and the general concepts in the 3-factor framework, which acknowledges that we need to think of the patient context, the nursing factors in context and the environmental factors as we talk through and think of what the right care activities are for our extern population. And what you can see on the right-hand side of the slide here is that we've really taken that accountability on at the professional practice and high level to make some decisions about what the permitted care activities are. And in our Q&A, we can happily pull up the details of these and talk through. But something that we really looked into and challenged ourselves with was thinking about some of the controlled acts, for example, that might actually be beneficial to have our externs participating in, and then working through how we would enable nurses to support that and do delegation in their practice. And really think critically about whether those activities would truly extend and almost like release a nurse's time to care further and focus on other aspects of care in partnership with the extern. So we really thought, what are those skills we want to add to our foundations at Sick Kids to extend nursing practice even further? We also took into consideration organizational risks that we know we have. So themes in safety reports or serious safety events that we are seeing, and made some conscious decisions about what not to include based on some of those. So one example for us would be the level of involvement that an extern might have in supporting enteral feeding, specifically NG or NJ feeds in particular, and made some choices to not allow them to do things like placement checks, for example. So they support enteral feeding setup, but we don't allow them to, for example, program the pump, check the placement of the tube, and initiate that feed. And so we were able to really, instead of just saying they can't participate in enteral feeding, really think critically about some of the sub-activities and what can they do in partnership that is really helpful to extend nursing, but still allows us to balance risk and our perceptions of risk based on our trends as an organization. And so I would really say, as an advice almost, that it is important to factor that in as well. What I find is that that is helpful in our conversations with nurses at point of care because they're very acutely aware of these risks. We have a robust safety program to socialize safety stories and some of these things. And so noting with nurses that we're conscious of that and why we're making some of these decisions about care activities has been really valuable as well. The other is that we know it's a little bit nebulous, but bringing in that critical thinking about, again, this is pulled from the 3-factor framework, but about understanding likelihood of predictability of patient stability across the organization, complexity of our populations, and what environmental supports do we have for the extern to carry out those activities. Again, we made decisions at the kind of professional practice organizational level in that regard, but what we did also do is consult with all of the leadership teams locally to decide if there may be additional things that perhaps are more predictable, less complex, and actually easier to support in their unique setting. So for example, there will be items on the list that will show you that some of our externs in the ED might not be doing compared to those that are working in our pediatric medicine area because the patient population might be less predictable, et cetera. And that's work that we're really leaning into to educate nurses on and help them also use their knowledge and judgment to determine what is appropriate as well. And so to that end, I mentioned that an important part of our journey this year was really diving into expanding some of the foundational interventions that externs participate in. And what we introduced were some of these things that you see on this list. And what was an important distinction for us as an organization was getting back to the basics of sorts. And this is where I suspect all of your unique organizational context will be important, is that because we don't have a history of needing to delegate as nurses, we needed to really help folks understand the difference between delegation and assignment with folks. And so we honestly also needed to refresh and make sure that we were really technically using the right language. We have a general history of saying we want to delegate and you want to share accountability with colleagues and receive help as nurses. But in this instance, we really did need nurses to understand what delegation means and what their accountability was related to that delegation of a controlled act because we were adding them this year. So that meant that we just, like I said, used the CNO's guidelines related to working with unregulated healthcare providers very specifically, and used that language and really looked to socialize that in different ways. And I'll show you some of the tools we use there. But if out of interest, you were curious about the specific skills, I've mentioned a few of these already, but we introduced some point of care testing supports, for example. I would say, fine-tuned our awareness of rectal temperatures in pediatrics, much more common. Being a controlled act that required delegation, I can admit that I don't think our practice was very solid related to that. We chose to introduce trach tip suctioning for some of our more stable trach populations, acknowledging that an extern is very engaged in that care, typically on our pediatric medicine or surgical unit, and that it is possible there might be a stable trach patient that could benefit from an extern having that ability, and engagement in urinalysis, for example. So you'll also note that, of course, urinalysis isn't a controlled act, but there are lab regulations that say who is allowed to conduct point of care testing. And so when you're thinking through whether you're going to expand, there's the context of controlled acts. There's also some of the other contexts of legislation, such as lab accreditation standards or legislations. And I'll be honest, our lab colleagues really helped us talk through this and made sure that we were being compliant with education requirements, access requirements, and making sure that they had all of the right checks and balances when we introduced these activities to them. We introduced a few things that perhaps seemed really straightforward, but we realized by talking to the leadership teams, we didn't have on the list before. So removing PIVs is a good example of that, where we weren't sure if it was happening consistently, but by really making sure we engage the local leadership teams, we could be really intentional about some of these things that seemed really simple, but we realized they did need education and support to complete. I talked a bit about the enteral and oral medication supports already, but we also chose to switch our medication admins from direct supervision to indirect. So our medication prep and verification steps, for example, where there's more risk, are direct supervision. And then we actually pulled apart the act of barcode medication administration and admin to say that they could do that under indirect supervision. So again, thinking about the entire care activity and all the little sub pieces of it, and what we could actually pull out to increase the independence of the extern in their practice and have them be able to really extend nursing the most. And you can see a few others that we've added. For us at Sick Kids, urinary catheter care is commonly a 2-person procedure, and central line procedures are always a 2-person procedure. Historically, we had said 2 nurses because of the level of attention to preventing CLABSI that we have as an organization. And we realized with the centralization of the program, we could really enhance their education and orientation. And so we feel confident now that with the right education, our externs can also be a second support for nurses to do those procedures. And I'd actually say we've had really good uptake in the ICU in particular, where I wasn't quite sure if nurses would be open to that for externs to participate in central line care. And that's been a really great win for us. So maybe I'll just pause there just to see if folks have any questions about the specific care activities that we permit. I can go through how we talk about education and competency next, but any questions about the activities themselves? And I can't see the chat stuff, so you let us know if you see anything.
Yeah, nothing in the chat right now.
Oh, Anna, I see.
Anna has her hand up, yeah.
Hi, Connie, how are you?
Good.
Question, the list that you're sharing on this slide, is this just an example or do you have a broader list?
Broader list, yeah. I can show it. I can show it if we want to look through. Also happy for it to be posted and shared as part of the webinar. This is really the new skills that we added for this year. So things that were stretching us just a little bit in terms of delegation. Yeah.
Thank you. And I was more curious around oxygen administration, if that was part of your list, and if so, what would that look like?
Yeah, it's not. And so right now, what we've coached folks through is using their nurses, I should say, through using their knowledge, skill, and judgment to decide if an extern perhaps assists. So maybe withholding a simple face mask with the nurse being present, for example, but the direct application of, we didn't add to the list because we kind of realized that the complexity, predictability part of it and being able to predict outcome was a little bit challenging. And we might evolve that, but we didn't choose to include that in the delegation list.
Great, thank you so much.
No problem.
And I think if I can just jump in, Anna, it's great to see you. Thanks for joining today. I think that what we continue to return back to and what has always been really supportive for both our nurses and our externs is reminding people that this list is based on our patients and what our patients need. It's not based on who the externs are or what they can do or who our nurses are or what our nurses can do. It's really always, we always bring it back to our patient population and what is safest for our patient population in terms of their needs for nurse extender care. So many of you on the call, you may make a different assessment based on who your patients are. And of course, it being the flu season that it has been, and the airways being as fragile as they have been this fall, I think that that was not a decision that we made during viral season, but I think knowing what we know now about the unpredictability of an acute pediatric airway, that's kind of the basis for our decisions. And we recognize as well that there may be others on the call who would make the same decision and others on the call who would perhaps make a different decision.
Mm-hmm. And to that end, we're really hoping to evolve the program based on the extern feedback as well. And so part of an activity we're undergoing right now is understanding which of these care activities are they carrying out, often, never, sometimes, and which might they recommend that they add. So I'll say there'll be some quick wins that they'll reach out to me for and say, hey, Connie, it would be really great if we could have access to do X, Y, Z. And it's straightforward enough that it makes sense and we can do that. And so I've really seen a lot of really good insights come from them directly and them understanding their role, both to extend nurses. So a lot of the stories are about the value of them just being present for patients and families to provide psychosocial support and how invaluable that is for nursing. And we know that's something that's unique to well, not entirely unique to pediatrics, but especially in pediatrics comes forward as being important, and then really recognizing that as being a critical part of their foundations as well. So. Okay, so we can keep chatting, of course, and we can pull up more details as we see helpful. We wanted to show you a bit of how we've kind of itemized what kind of underpins the successful onboarding and ability for externs to carry out the many activities that we've permitted them to do. And so we've really optimized this year by pulling out the pillars of what does a centralized education program look like? How do we verify competency? As a reminder, that's really critical for our ability to delegate specifically, and a requirement of delegation is making sure we can ensure competency. And then alongside that, how do we make sure both externs and nurses understand the context of delegation and what's required of them? So you can see for education, we really leaned into centralizing as much as we could, both to kind of alleviate the local leadership team's burden, but really make sure that the externs, what's important to me is that they have kind of a community or shared experience amongst themselves as a group of new learners, folks that are new to sick kids, and developing their careers with each other, and then also within their local teams or home areas that they're working in. So bringing them all together has been really valuable actually for them to get to know. And I was joking with others, like they have a WhatsApp chat together, even though they don't work in the same areas. I don't know what they talk about, but they've kind of really connected as a unit. And I'm hopeful that lots of these opportunities we've had to centralize has meant that we brought them all together to support each other as well. So they're supported with central hours that looked like 2 central days where we really went to the details of pediatric assessment, really making sure they understood the details of all of the skills that we were requiring of them and that are available to them. And then also include some self-directed learning time and time to do some of the e-learning modules that they have as well. We offered 2 shadow shifts in their local areas, and this was organized by the local leadership teams. And what we really said to folks at the local level is that we wanted to work within a 2-week window so that we knew kind of upfront we have a finite amount of time when they're working full time with us in the summer, that we could get them in, get them trained, get them shadowed, but really practicing to support extending nursing care and patient care within 2 weeks of onboarding. So looking at front loading as much as we can to enable them really just getting into practice as soon as we can. I'm happy to share more resources on this if you're interested. And again, we can make sure it's posted with the webinar content. But what we then did for the expanded skills, so not all of the skills that they're required for, but with some of those maybe higher risk skills or newer skills that require delegation in our controlled access, we do require them to have 3 practices observed and signed off. And so they have a simple kind of competency checklist, and any nurse at the local level, the local educators, or some of our team members that are in a role called a nursing practice observation lead that already provide coaching and feedback to nurses can observe their practice and sign them off. So for example, the extern that's taught central line care would be expected to be observed for that central line care practice 3 times, be signed off, and then they could be deemed competent and continue to participate in that activity, of course, but without that observation first. They have just a little pocket card, and again, we can share that with you, that allows them to then hold that. That was critical to make sure that we were meeting the requirements for competency review and documentation when a nurse delegates a controlled act to them. So again, one of those details that might seem small, but that was critical to make sure that we had all of the nursing accountabilities for delegation addressed, and happy to answer more questions on that if they come up. And again, a really important part for us not having an existing structure for delegation at SickKids was making sure we leaned into nursing education. And so in the outset, that looked like us going to huddles, really talking about your professional accountabilities as a nurse and what that accountability means for how you document, communicate, and close the loop related to delegation and how you make decisions about that. We did have to pivot because of a lot of the challenges and constraints locally and the ability to get folks' attention at huddle. And so we created an e-learning module that nurses have access to. It's 10, 12 minutes or so, and it really distills down the key facts of what they need to know accountability-wise and how that looks for them in their practice. And that's posted and available. We also, I will say, have a public link available, so we'll make sure that that's included in the webinar posting. So if you want to peruse it, you're more than welcome to. And we're open to you, of course, borrowing whatever is useful for you as well. We have opportunities to refine documentation, but documentation for nurses occurs in the electronic health record. So ours is Epic and a progress note. We don't have a fancy checklist for delegation. What we've asked is just that nurses document the delegation before the end of shift, and they as a requirement, must document what was delegated, who they delegated to, and what the patient response was. And so what we encourage folks to do and what we really lean back on is our safety behaviors of closed loop communication and always staying accountable for their practice and really heightening that awareness. And so this will be something we're really paying attention to as we evaluate, because again, it feels new. We know it's not entirely new, but I know it's feeling new for nurses in particular. And something that we've been kind of navigating by getting out and about and talking about practice more and talking about enabling delegation in particular. And I'll turn it over to Erin.
So I thought it would be important to talk about the things that really helped us take off and in terms of enhancing the program and centralizing it, and some of the challenges that we would want to know if we could go back. Some of the things that we want to share with you as you perhaps consider the opportunity for nurse extenders in your organization. One of the things that really was absolutely foundational to expanding the program was a very long-standing history of extern programming within the organization. Most recently, probably I would would say over the last 15 years, we have had externs in the organization, and they have been onboarded in a decentralized way. So perhaps 1 or 2 externs in cardiology, hired by the cardiology manager, but disconnected and not related to perhaps the 5 externs that were hired in pediatric medicine. And there were very locally driven practices of assignment and locally driven practices of modeling. So some of those externs might have been one-to-one, some of them might have worked in a team model, some of them might have supported a unit or a cluster, some of them might have worked days, nights, and weekends, some of them may have only worked Monday to Friday. But however, that being said, is this long-standing history of extern programming from the Learning Institute and Bonnie Fleming Carroll and the local educators really was absolutely the foundation for expanding and bringing together a centralized model. One of the strengths as well was our ability through centralization to equitably distribute the resource. So as I said before, perhaps this was a previously locally driven decision and locally funded. And by pulling our funding together and hiring one large workforce and then distributing that workforce equitably, we've been able to really capitalize on the strengths of the nurse extender for all of our patients. And no matter where our patients are, they can benefit from that resource. Resource distribution of the 50 externs was determined based on staffing gap, ability to hire new graduates, in addition to the size of the program. And so we had a very transparent distribution model in order to allow all of our units who were receiving externs from the program to understand that distribution. And we've learned a lot about that model and how we would probably make some changes for next year. Another strength was our proven track record of promoting externs into RN positions. So while we had not been tracking this, we do have a lot of anecdotal evidence that our externs historically were very successfully promoted into RN positions and beyond. Connie will give you a little wave because Connie's career started here at Sick Kids as an extern. And there are many, and actually I think Krista as well was an extern. So externship at Sick Kids historically has been a really great place to nurture talent. Local flexibility to deploy the externs to meet patient demands. I think that we really experienced a lot of local investment in their own extern model and the best ways to have externs support patient care. And we as a central model, we do our best to meet units where they're at and meet their patients where they're at and work with them to deploy their externs to the shifts, to the care activities that make the best fit for them. And also, I think one of our major strengths was the credibility within professional practice, our knowledge of the college regulations, our ability to speak to the acts of delegation, our ability to support nurses to understand how well they could practice with nurse extenders within the scope of their license. And our credibility to do that allowed us to really centralize those practice expectations and that were readily accepted across the organization. I think some of the challenges we experienced were actually balanced by our strengths, and so they're set up on the slide in that way. I think that there were many units that actually did not have good experience with externs, or not good experience, did not have recent experience with the extern model. And so we did have to do some change management with some of our areas who were going to receive externs, but perhaps had less understanding of the skill set or less understanding of how to optimize the role. And I think we're trying to manage perhaps with a more limited lens on the resource and how the resource could be used to maximize patient care. We did learn a lot when we introduced the extender to new areas in the emergency department and critical care. Even some of our inpatient surgical areas had not had externs in quite a long time. And that really just required leveraging our relationships to work with local units on the approved care activities list and to really encourage them to give us feedback on how things were going and be available and supportive to them as they introduce this new role to their teams. One of our challenges continues to be this cultural influence on delegation and assignment. You know, I'm sure you'll experience this in your own areas where, you know, this idea that if you're a good nurse, you should be able to do it all. You shouldn't have to delegate if you're doing a good job already. And so we really are working with our teams to continue to move forward that what's good for patients is in turn good for nurses. And what's good for patients is to make sure that they have the broadest availability of resources to them to provide care in a way that is wholesome and complete. And I think that that's where we've been able to move the needle the most. There are some areas that we're very, very used to the extern model, and we're very happy to expand with the delegated activities, with the increased enhanced activities. And there were some units for whom there was less comfort, and they said, we'd like to restrict what they're doing. We'd like to actually keep a tighter lid on this. And that's just really required openness on my part and Connie's part to understand what's at the heart of the matter. And generally what we always uncover is the uniqueness of each individual subspecialty patient population. There's just a lot of special patients. I'm sure you have special patients in your areas too. And our nurses are really the best intel on their patients. And it does really just require mindful listening and presence, and also painting the picture of what might be possible to allow people to understand that where they're trying to control may actually not be achieving the benefit or the outcome that they're desiring. We do have a decentralized scheduling model. So we do have our local leaders scheduling their externs. And so what we do find, we tend to struggle with defining the organizational impact of this workforce on any given shift. And that is something that will work for continuous improvement next year. And one of our other challenges, I think, is managing the expectations when you centralize an entire workforce, is to manage expectations and to just move forward with really good change management principles in mind. And we navigated this actually by holding a number of town halls so that questions could be asked freely and feedback and opportunities for improvement could be shared and received in a really open venue, and that leaning into our credibility as the professional practice office to let people know that we were partners, and that this could not be achieved without collaboration between professional practice, education, and clinical operations.
I think what's dawning on me, Erin, so I'll add to, is I think a way that we've navigated some of the centralization and the hope to balance folks understanding the skill set of the extern, how to maybe schedule a different move around, has, I think, been related to my role in being that liaison of sorts, not just for people leading them as externs, but representing what they are capable of in many spaces. And so my role, yes, is kind of a central org level role in that I manage professional practice with Erin, and I have that reporting accountability, but it's also meant that I now sit on the inpatient manager meetings, and I sit in our bed flow meetings, and I bring that lens there. So it's meant that some of that socialization is informal, in that I do kind of think of how I stretch folks daily to think of how an extern might support where we may have nursing staffing gaps for that day, that moment, that evening that's coming up, looking ahead to the weekend, how the extern workforce might support folks. And that's both thinking of their skill set and what skill-based needs patients might have, and also thinking about scheduling differently. To that end, we've really also set our extern workforce up to be able to float across areas. So they are dedicated to home areas, but they have been really excited to float because they want experience across others. And I think because we've centralized the education and streamlined things, they've also felt supported and set up for success to be able to do that. And so I think something to ponder perhaps is where is the voice of influence in many different places, and I've seen a benefit to there being a voice for how to leverage externs in the clinical operations space for us in particular, and thinking through that, especially if we're in this time of staffing challenges for nursing as well. I think I didn't want to miss a question. Oh yes, we will share the list of interventions as well. And so as Erin, we've kind of both talked through some of the things that are on the horizon for us as we kind of centralize the program this year. We're kind of in the throes of these early offers that we have for our current extern pool in particular. I talked a bit about the performance review process and how, again, having them be integrated as staff at the hospital means that we're also paying good attention to how we set them up with some of the expectations that we already have of nurses that work at sick kids, which includes performance review. And so we'll be launching that process just shortly for the externs specifically. Quite kind of cleanly, they'll set a personal goal, and then they'll be required to get peer review feedback. And then I will lead a review with the local manager, and we'll be able to talk about what's enabled their success and what might set them up for success as they hope to transition into a role as a nurse at sick kids as well. What we're hoping is that helps also build their self-efficacy as they're new nurses getting into the profession, and can build some of their resilience along the way as they set themselves up as well. Sorry, we just have an announcement overhead. We are looking at the broader kind of overall aspect of evaluating the program on the whole, and thinking of our hiring practices and overall satisfaction as well. I think we've just recently done a pulse check with folks, and this quote has come from that. So it's kind of hot off the press, but I asked them, like, what advice would you give to new externs that start with us? And Vanessa, who's one of our externs in the ICU, shared this concept of it can be intimidating at first being surrounded by a team of such highly educated and experienced healthcare professionals, but give yourself grace and patience. The most amazing journey started once I realized that there were no stupid questions and that I cannot compare myself to others. I've been able to learn so much just by sitting in on rounds and asking the nurses to explain things to me. So her advice was build relationships with nurses who like to teach. They are so valuable. And I can say that of the 30 folks that I have that responded already as of yesterday, this general sentiment has really kind of echoed through. And for me, what it's spoken to is the bidirectional way that we do need to coach and support nurses to know how to leverage externs as a workforce to extend, but we also need to empower the externs to be able to show that initiative and to partner with and grow that with them as well. And where we have folks like what Vanessa says that are really able to kind of step in and feel supported to do that, to speak up, to have psychological safety to kind of navigate through that new experience. We have seen success with greater uptake as well. And so something I lean into as the centralized manager is thinking of how I continue to build that with them, and how we build their self-efficacy and autonomy to raise concerns as well, and chat through how they see they could impact their own practice and build relationships across. So it's been really great to start to get more of their feedback, and we're definitely looking forward to thinking of how we leverage that for the new group that's going to start with us soon. And so to that end, we do have other resources that we'd be happy to pull up and share, but we really just wanted to turn it over to you and see what questions you have for us. And also we'd love to hear about your own experiences too, because we know some of you have externs as well.
I just wanted to say thank you. This has been a really helpful and informative presentation, and it certainly speaks to a lot of the challenges and the importance of the due diligence behind the scenes when you're implementing these kinds of models, specifically around, you know, I like the idea of breaking down certain procedures into smaller tasks that maybe can still free up nursing resources while not completely assigning something to an intern. So really very helpful. Thanks so much. And I'm looking forward to being able to see some of the checklists and things that we can use in our hospitals as well.
Yeah, thanks, Paula. It's true that kind of taking a more strengths-based lens versus a deficits-based approach has really helped us, I think. Thinking about what is possible and feasible versus what isn't on the whole has, I think, really enabled. So would recommend, yeah.
Connie, I think Anna was next, and then I have a question as well.
Two quick questions. Thanks, Krista. One is thank you for the presentation, and we're always learning from each other. So this is a great opportunity to learn from each other. One is, out of your experience around the extern, were there any medical directives that need to be created to support the delegation piece? And can you share any of those examples with us?
Yeah, we didn't go the route of medical directives because traditionally at sick kids directives are coming from ordering providers. So physicians, I'm technically you could have from some NPs, but we don't. And so it would be really out of our usual practice to do that. And we felt that the delegation, because they work under the supervision of nursing from nurse in the moment, better allowed them to assess those patient factors and environmental factors. So the complexity, the predictability types of things in particular with them as unregulated care providers. And so we didn't go the directives route. And we wanted to honestly, I'll admit, keep it a bit simple so that administratively, it was a bit more straightforward for us. Yeah.
Thank you, Connie. And the second question, knowing this model that you have you attempted or are you planning and adapting to other clinician types, not just nursing, OTs, PTs, RTs, that type of thing?
We are. So we're currently onboarding, and we will hopefully be posting in the new year for interprofessional externs. What we're doing right now is making sure that we understand those patient care activities that we have for our existing workforce, and that we have a good sense of how much that needs to be adapted for different professionals. What we're finding is actually it doesn't have to be adapted that much, which has been a great finding, but really comes down to, what we would call QVV, which is like question, validate, and verify, and making sure that our understanding of scope when it comes to other professionals is being well reflected by an extender. So it will very likely be that our interprofessional externs are still working as nursing extenders, except what we're finding is in the case of respiratory therapy, that there is actually a really good utility for our respiratory therapists to have RT extenders, but that our OTPT externs will very likely function as nurse extenders. So we'll have to pay close attention to that socialization and what that will look and feel like for our teams. But we have just tremendous interprofessional colleagues in our RT and our rehab services. And so it's actually just like been a really positive project to work on in these times. So yeah, we will be looking forward to introducing those professionals to the model soon.
Thank you so much.
Krista?
Connie and Erin, I have a little bit of a provocative question, but I know you're up for it. And I just wanted to say hello to everyone on the line today. I know many of you have been working for some time within the GTA Chiefs table. I'm Krista Kelty, Associate Chief Interprofessional Practice, Connected Care, and System Integration. And so the question I'm going to ask is, we have two main aims with our externship program. Of course, the importance of nurse extender, bringing the right care resources to the patient, but also the pipeline. What do we predict in terms of retention for this group of nurses? And where might we recognize strengths in those who we don't retain that might otherwise be able to support the pediatric workforce that we know is experiencing scarcity in terms of resources across the system? And I'm seeing some heads do this. So I just thought I might ask the question.
So if I could just repeat and parse out and make sure that you want to understand what are our goals for retention of externs. What is our promotion rate? What are we aiming for? And for those that we don't promote into nursing roles, how will we understand their experience as it relates to pediatric nursing as a professional choice? So
and maybe Erin, and where might we understand how to retain their strength and interest in pediatrics in the overall workforce that may not be within our organization in 2023, because there are other sectors where we have pediatric patients.
Yeah, so I think that the first answer is we do aim to promote 100% of eligible externs into nursing roles. That's that's the goal. Recognizing as well that our externs are also students. And so while we are giving them what we feel is a very good employee-employer experience, we know that they're also working in other organizations, they are working in other sectors, they are also experiencing other specialties, and that their aptitude may be leaning in one way or another. So for those for whom they choose to not apply to Sick Kids as an employer, we're taking what I think we would call a concierge approach. And that is, again, leaning into the relational capacity that we built amongst them and with Connie and myself. And so I think what we would do is have a really a good heart-to-heart with someone who is going to end their extern contract and not choose to work at Sick Kids, and understand the gap between the two. And if the gap is not related to pediatric practice, but perhaps is related to not wanting to work downtown, working closer to the GTA, having commitments that require that person to be elsewhere, I'm anticipating a couple of reasons, then I think what we would do is absolutely do our best to set that person up for success in terms of pediatric practice. What we have found historically upon like a look back of our past externs and where those externs have ended up, our previous promotion rate sits just under 80% of our externs, and we have seen our other externs choose other employers either related to intake date, so they wanted to work sooner than our intake dates, or into areas where we don't currently hire new graduates. So critical care areas in the adult population being a primary draw for our new grads, and we don't hire new grads directly into critical care. That being said, is for those externs who are interested in critical care at Sick Kids, we will promote them into the residency program at Sick Kids, which is an entirely other fantastic new initiative at Sick Kids. Does that address? So yeah. I think for the gap, we're aiming for everybody because the feedback has been tremendous. The evaluations have been wonderful. The workforce is passionate. However, recognizing that that's a high goal, I think we would take a concierge personal approach to those candidates who feel like a career at Sick Kids is not a fit for them.
And I'd add that I see that as the other benefit to us centralizing. So it's easier for me to stay attuned to what their strengths are. And some of the kind of fit assessment has also been my ability to really think about some folks, for example, in our group have relocated areas. So perhaps emergency department wasn't a great fit for them. And we could actually relocate them to an inpatient area that is a much better fit instead of perhaps a risk where they might have left the organization because of that fit concern for them. And I've been really impressed with their ability to reflect and even actually come up with some of those thoughts and ideas themselves. So it's not others raising the concern, it's them being really reflective of what they are hoping for in their nursing career, their strengths, and how they think their strengths are best leveraged, not just in pediatrics, but in the types of care settings that we have. So you're right, Krista, us thinking about that broadly beyond our organization will be important as folks are learning a bit more about what types of nursing care and which aspects of practice they're really interested in, and staying connected, I think, on that will be really important too.
Thank you. Can't thank you enough for bringing this talk forward. It's been an interest among many on the line today, and as you've stated, many others have been sharing their learnings as we move through this surge activity. So it's been fun to learn from you today. Thank you so much for being here.
It is always our absolute pleasure. Yes, I do see Anna's question in the chat that the 0.3 FTE during school could be ambitious. Are you able to see consistent availability? How did you come up with a 0.3? So a 0.3 we felt like translated to effectively 1 12-hour shift every week. And we felt like that would meet the operational need in addition to being as manageable as possible for a student. That being said, there are at times individual considerations that need to be taken into effect. And our goal is to always retain at the lowest FTE we can, rather than make the 0.3 a deal breaker. And so we've had only actually 3 folks, Connie, drop their FTE, and those are actually folks who live quite a bit of a jaunt away from the Toronto downtown. And the rest of our workforce has been managing the 0.3 FTE beautifully. So we feel like that's been a successful number, and it's a value that we continue, not like a head count of 50 at a 0.3 FTE really sits around the 16 FTE mark. Mm-hmm. And if we were to go lower than that, we perhaps would keep our externs really happy, but we would minimize the impact to patient outcomes. And as I said before, one of the main aims is to really make sure that we're driving outcomes as it stands with patient needs for nurse extender roles. And if we dropped lower than that as an expectation, I think that we would probably start to minimize the impact, which we don't want to do. But that being said, what we do anticipate and we do offer, which I don't think we said, is we do offer an unpaid leave of absence for consolidation for students who want it. So we recognize that when our students stop attending in class and they move to a full-time preceptor consolidation model, that extra shift can actually really be the make or break between burnout for many of those folks. And so instead of ending their employment record, we will give them an unpaid leave of absence during their consolidation and encourage them to either return to the extern role or be promoted into an RN role after their consolidation.
Yeah, and to that end, we haven't had those requests just yet. We've had, for sure, folks that have needed to move shifts, and we've been flexible because they are temporary and contract to, if they need to move shifts, to work together to do that. We know we have the needs, and so our willingness to be flexible has been helpful and has still really supported patient care needs as well. So it's been good so far.
Irene, you have your hand up?
Yeah, I know we're over time. I just wanted
we can stay. We're fine to stay.
Yeah, I'm happy to stay. Yep.
Sorry, just a couple of threads from what I've heard. So retention is such a critical component, but I think we ought to be cautious not to measure our success in these programs only by retention to our own organizations, because what we hear is the pool of pediatric nurses are so small. So, I was surprised we didn't retain as many even in our own program at Hull and Bloorview, but it's okay because we're training pediatric nurses in general. So just a little bit of a thought there, so that we don't pin all of our success to our abilities, because students come from all over, they travel, most of them out of town for school, and then at some point they come back home or they move. So they are a very mobile group, and we're contributing to the future of pediatric nursing. So I think what you're saying is really important. Thank you for the presentation.
Yeah, thanks, Irene. Your points are really well taken to heart, and I think that, of course, that has been a really interesting journey for Connie and I, as we really want to mobilize a useful workforce for our nursing staff who are just so stretched right now, that we really want to set our sights high, because we want to fill those vacancies with this passionate workforce. But your point is very well taken, because I think that regardless of retention of this specific workforce, I think we do know that we're giving them a very good employer experience. We do know that they are a highly mobile workforce. There's incredible demand for these bright, intelligent nursing superstars, and we know that they can choose to go anywhere. We just want them to choose to be at Sick Kids. And we also know, as an organization, we have a very fantastic track record with past externs. Many of our managers were at one time an extern. Many of our other educators and leaders, Stephanie's waving, Connie, I think Krista, you have to let me know. I thought you had said at one point that you were an extern, my mistake. But so we also know that anecdotally, that we have retained a lot of externs. But I think, your point is well taken. If my goal is 100% and I don't meet 100%, I won't take that too hard to heart. And we certainly have not found that our current extern workforce feel trapped here, or you know, as though there are many jobs out there, and this is a very desirable opportunity for them as it is for us.
Thank you all. Another dark night, dark drive home. Thank you very much. And thanks, Steph, for pulling us all together. Was there one more chat? Are we good?
No, I think that's it. I did put a link to an evaluation for those that are still online if you want to give a little bit of feedback. Otherwise, thank you for joining us.